Hi Sahar, thanks for coming by. I wanted to discuss a patient case with you and get your thoughts on warfarin dosing, please.
Hi, Dr. Mehdad. Sure.
So, Mary Kay is a 68-year-old woman of Asian descent. She presented with increasing fatigue and shortness of breath. Echocardiogram confirmed severe mitral stenosis and newly onset atrial fibrillation because we had a previous ECG in which there was no atrial fibrillation.
Oh. Given her valvular AF, warfarin is clearly indicated. Have you started her on therapy yet?
Not yet. I ordered pharmacogenetic testing first, and here is the results.
Yeah, her results show CYP2C9 variant 2 and 3 and VCORC1 1639AA variant. They are significant, and CYP2D6 genotype 1 and 1, so it is not significant. Both CYP2C9 2 and 3 impair metabolism of warfarin. About 30 to 40% for variant 2 and 80 to 90% for variant 3. And VKORC prevent carboxylation of the vitamin K dependent clotting factor, and 1639AA is common especially in patients of Asian ancestry, so like Mary, our patient, and make her high sensitive to warfarin.
So I was thinking starting her on 2 milligram of warfarin daily and checking her INR in 3 days. What are your thoughts?
And lower dose is indicated. And there are some research behind that. For example, CPIC and IWPC guideline both support lower initial dosing for patients with this variant, and the EU PACT a study even shows improved INR control. And if you like, I can check her dose using the pharmacogenetic algorithm calculator, IWPC warfarin dosing calculator.
Sure, thank you. What are the informations that you need?
Her age, her height, her weight, genotype, race, and any current medication.
So she is 68 years old, 165 centimeter tall, and weighs 75 kilogram.
Yep.
And I have the list of the medications as well.
Oh, perfect. Yeah. So based on her genotype and Asian ancestry and no enzyme inducer.
Carbamazepine, I guess?
Yeah.
No, she's not on carbamazepine.
And no on amiodarone.
No, she's not on amiodarone either.
Okay, so calculator predict a weekly dose of approximately 7 milligram, which work out to 1 milligram daily. Given her sensitivity, I recommend 1 milligram per day and adjusting according to INR.
Interesting. That's even lower than I expected. Thanks for running that. By the way, didn't the COAC trial show no benefit from genotype guided dosing in a mixed population?
Yes, you are right. But the trial didn't account for African specific CYP2C9 variant like 5, 6, 8, 11. So many participants were underrepresented in Asian and European population. Genotype guided dosing remained beneficial for initial dosing.
Just to confirm, genotype-based dosing is most useful during initiation, correct?
Exactly. Once reached a stable INR, the genotype become less predictive. We need to also consider phenoconversion, which is when clinical factor override genetic prediction due to external factors such as drug interaction, disease state, or lifestyle. For example, amiodarone or azole antifungal can inhibit metabolism of warfarin, or illness or liver dysfunction can affect INR control.
Here is the list of medication. Would you please check any phenoconversion, please?
For sure, metformin and rosuvastatin. Yep. So she isn't on any enzyme inducer or inhibitor, but I noticed she's currently on rosuvastatin 10 milligram. That's worth flagging. Rosuvastatin may increase warfarin anticoagulant effect, and according to AMH, so atorvastatin are better option with minimal INR impact.
let's see, I'll switch her to atorvastatin. I'll initiate warfarin at 1 milligram per day and review her INR in 3 days. How about that?
Oh, excellent plan. I document the changes and flag any, interaction.
Thanks, Sahar. This is a great example of how pharmacogenetics and pharmacist input can help personalize care. Have a great day. Thank you.
Thank you.